Stop talking, Cynthia.
Okay. Okay. Good afternoon. Today is November the 12th, 2025, and it is 1:07 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Strategic Planning Committee. As a reminder, a committee member may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. Public communication, is there any public communication, Valerie? No. All right, we have no public communication today. So we're going to continue on to the agenda. Number one, review and approve the minutes of the June 11th, 2025 Strategic Planning Committee meeting. Do I have, yes, Cynthia?
I move that the committee approve the minutes for June 11th, 2025 Strategic Planning Committee meeting.
Second, thank you. And all in favor? That's it, okay. All right. Number two, receive and discuss a report from the President and CEO on fiscal year 2025 accomplishments, priorities, and key results. Dr. Lee will be presenting.
Ready? Okay. Good afternoon, board managers. Following the close of fiscal year 2025, I want to take a moment to pause and reflect on what we've accomplished together, what we've learned, and where I hope to grow as a leader in the year ahead. I'm humbled by the privilege of serving this community and leading Central Health, whose mission and people inspire me every day. Each of you has played an important role in shaping how I lead, and your guidance, candor, and partnership have helped me grow as a CEO and as a person, and for that I'm deeply grateful. FY25 was a year of remarkable progress thanks to your leadership. Together we took measurable steps to expand access, to improve outcomes, and to build trust across Travis County. We opened the long-awaited Del Valley Health and Wellness Center this summer, and what a wonderful celebration that was. We delivered more than 500,000 primary care visits in partnership with Community Care. Over the past 2 years, we stood up an astounding 30 new specialty, diagnostic, and high-risk service lines, from cardiology and podiatry to palliative care and nutrition. Every one of those services closed a painful gap in care for someone who might otherwise have gone without. Through our Bridge program and mobile teams in partnership with EMS and other community organizations, we expanded care for people experiencing homelessness. We opened a new 50-bed respite center, creating a safe place for people experiencing homelessness to heal and connect with resources, including stable housing. By meeting people where they are, on the streets or in the shelters, we offer pathways to stability. Because we all know healthcare is more than about just treating conditions. It's also about restoring dignity. We are becoming one integrated system, one team, one mission. Central Health, Community Care, and Sendero now move with shared goals and a unified leadership structure. We're united behind the Year of Access, which is more than a slogan. It's become a blueprint for a seamless care journey across our county. And that includes mental health. Under the guidance of the Central Health and Integral Care boards, our teams came together to study national best practices and co-create a unified model that brings greater coordination, compassion, and strength to the mental health system serving Travis County. In FY25, we also strengthened trust in new and bigger ways because listening is how we lead. We hosted community conversations with Travis County commissioners and Judge Brown, multiple CEO roundtables, and our first ever Spanish language Vivir con Ganas Health Expo. It was a magical day planned by our staff and community members Nearly 460 people attended in person. More than 200 watched our live broadcast. Thank you, Manager Valadez, for helping bring this vision to life. With the board's leadership, we're forging stronger partnerships across our community, rooted in trust, shared purpose, and mutual benefit. With UT Dell Medical School, Austin Public Health, Austin Community College, Integral Care, ECHO, the Black Men's Health Clinic, Hungry Hill Foundation, HAM, and many others who share our commitment to health equity. Together, we delivered a balanced budget, maintained healthy reserves, and earned unanimous approval from the Travis County Commissioners Court for the second year in a row. And that vote signaled something rare in government: unity and trust earned through discipline and transparency. Additionally, our newly established Board Philanthropy Committee, led by Manager May, advanced a plan to generate vital philanthropic revenue in support of Central Health's long-term financial sustainability. Working with CommuniCare and Sendero, FY25 was our first full year using system-wide objectives and key results. The OKR framework gives us all a shared language for success. We didn't hit every key result, but we built the muscle of alignment and measurement. We are working on data dashboards, establishing baselines that will allow us to track progress around access, outcomes, and community sentiment year over year. We improve coordination across departments and system partners to reduce inefficient duplication. We're working towards our FY26 moonshot goal of reducing appointment wait times to less than 2 weeks across the system. 3 lessons stand out for me this year. First, trust is our core business. Every success, every service line, every partnership started with trust. Second, we must transform data into dignity. Data isn't just about how many people we see. It's about who we reach, who we miss, and what barriers still stand in their way of accessing high-quality health care and health coverage. Third, leadership requires presence. The most meaningful moments of trust don't happen during a PowerPoint presentation. Those moments happen when we show up. It's the time spent with patients, with partners, with teammates, and in the community, and of course with you. This year, you encouraged me to listen more deeply, to communicate more clearly, and delegate more effectively so others can grow. I took your wise counsel to heart, and I hope you've seen and felt the difference. I've worked hard to lean into that guidance through weekly briefings with our board leadership. Thank you, Chair Kitchen and Vice Chair Brinson. We have strengthened communication channels and our focus on team development. Meanwhile, Guide with Love principles are taking root across the system through the Big Listen, lean improvements, and recognition programs that connect our people to our purpose. FY25 laid the groundwork for what we're calling our Year of Access. Together, we are building a system that is more integrated, more equitable, and more trusted. A system that reflects the will and the values of the people of Travis County. The path ahead will not be easy, but as I often say, optimism is a moral choice. And we choose optimism because the alternative is morally unacceptable. Thank you for your partnership, for your guidance, and for your trust. It's the greatest privilege of my life to serve beside you. Together, we are building a community where everyone, regardless of circumstance, has the opportunity to live a healthier, longer life and thrive with dignity. I want to close with a special mission moment. Isa Farino is a new nurse at Rosa Zaragoza, but her story with us began years ago when she first came to that clinic as a teenager seeking care. From patient to provider, Isa's journey captures the very heart of what we do. Her courage, persistence, and compassion reflect the spirit of our team, people who show up every day to turn care into healing and hope into action. It's because of people like Isa and all of you that this mission is more than words. It's a promise we live every single day. Thank you.
My name is Isa Farino. I'm the nurse manager for the Bridge team. I started working with Central Health in June of this year. So a little bit of my story that kind of led me to Central Health. When I was 15 years old, I became pregnant. Becoming a mom at a very young age, it made me to realize how resilient I had become. Just choosing the career in healthcare and going through nursing school, I was working, full-time while going to school full-time, as well as being a mother. But I think there was one point where I really asked myself, is this really what you want to do? And I couldn't think of anything else I would want to do. So I knew I had to, keep going and keep fighting for my daughter and for the person that I knew I could become. A big part of my journey that led me to Central Health was my time at Rosewood Zaragoza. The MA that took care of me really inspired me to kind of do the same work. And once I became a nurse, I knew that eventually I wanted to do the same thing she did. I was very excited when I heard about the Bridge program. The work that they're doing for the Travis County residents is really amazing. We're able to kind of meet them where they are, which is huge when there's a lot of mistrust in the medical community. We're able to spend time with them, talk to them, figure out what's truly important to them. I think that is one of the biggest ways that we are able to make an impact. My daughter and I are best friends now. She's 16, and I'm proud to say that she still thinks her mom is cool. She still wants to kind of follow in my footsteps, which is something that I'm very proud of. She wants to ask those questions, like, how can we help people? And I'm very proud of who she's become.
Okay, does anybody have any questions? No? No questions? Okay.
I have questions on some of the information in the backup, so I don't know if this is the time to do that. You want me to go ahead? Okay. So, I have a question about the, let's see. It's the OKR, related to, member enrollment and engagement. The part of it that talks about complete analysis of resource and other factors impacting the capacity to increase enrollment and consider approaches to expand capacity. I didn't see that in the text on completion to date, so. And if you need to get back to me, that's okay.
I'm so sorry, I was trying to find the correct page.
It's page 24.
Page 24, okay.
Like I said, if you need to get back to me, that's fine. I'm not seeing anything written about progress on that.
Okay, yes, let's get back to you on that.
Okay. And back to me means the whole board.
Yes, yeah.
Okay. And then the other question I had, if it's okay, Chair, just one other question.
Yes.
So, well, I might know the answer, but I might need reminding. So the health equity plan is our plan that we're monitoring implementation on right now. So I am trying to connect the dots between the health equity plan and what we have in our backup about fiscal 2025 accomplishments. So can you help me with that? In other words, our anchor right now is the health equity plan. And so one of the jobs of this committee is to monitor implementation of the health equity plan. So you got quite a bit of things here about accomplishments, and you also have the tie back. You have the tie back to the OKRs. I'm not clear on how the OKRs and how this information ties back to the plan that we're following now. And again, if you need to get back to us on that, that's okay.
Sure. Thank you, Chair Kitchen. So if you go to page 23,
23, okay.
this is the budget resolution, objectives, key results.
Yep.
These objectives directly tie back to the health equity plan, so increasing access and capacity,
Okay.
care coordination, member enrollment, engagement, and system of care infrastructure. Those are the 4 pillars of the healthcare equity plan.
Okay.
And then within that, each of these key results that were part of our core budget focus in FY25, those are directly linked to the plan's rollout. As you may recall, we were in year 2 of the plan last year. We're heading into year 3. And so these expanding access to specialty care, for example, was one of the primary focuses of the plan. Healthcare for the homeless and respite care was another key part of the healthcare equity plan, and so on and so forth. So these specific key results and the overall objectives are a direct expression of that plan in year 2.
Okay. Didn't we say what kind of specialty care access we were gonna expand, or is this? I'm gonna have to, you know what, I'll just spend some more time with this, so I can connect it, but I hear what you're saying in terms of how this connects back, but, and I think it's in our backup twice. Anyway, never mind. Keep going. I'm gonna have more questions, but I can defer them. So,
Anyone else have any questions? Yes. Yes, Joe. Maram, do you have a question?
Yes, does Dr. Martin want to go first?
Well, I don't have a question. I know this links at this point, but on page 28, the Develop 5-Year System Transformation Design Plan, I find it hard to see how this will ever get to 100%, because I don't know that we have a true transformation plan in place. And I wanted to bring this up kind of as a suggestion to the Board of Managers that all of us that went on the visit to San Antonio could perhaps sit down with some points that we learned at that visit. And I think to create a matrix for ourselves, to give them a policy guide of the different aspects: delivery of care, acquisitions of property, relation with the medical school, relation with the Mountain County Commissioners. But I would ask of the Board of Managers, those of us that went, to bring back to our next meeting points that we took away, 5-10 minutes for each board manager to discuss our takeaway points. I think for us to allow for a truly transformational policy to occur, to give them guidance. I think this will never get to 100%. I don't think the plan has been articulated. And I think it needs to be more of a high-level policy to drive this ship to some extent. We have so many balls in the air at the moment, and I learned so much from that visit that I think we should, I think of all of us did that went. It was truly an amazing experience. I think that to bring that home and give them the direction to, we have so many things we have to create, and I think that to give them that would be beneficial. So I think to get that from the board.
Yes, yes.
I think that's a good idea because people had a lot of takeaways that really would be helpful, you know, for us all to talk about and integrate. I think though that's just one piece, and I think this OKR probably needs updating because it's talking about a 5-year system transformation plan, care delivery, capability, capacity, infrastructure plan. So that is different than, okay.
Well,
All right, no, wait, let me finish. Because to me, what I'm thinking of in my head is, I didn't mean it was different than what you said. I'm just thinking through, this body is responsible for developing a strategic plan, okay, that goes to the board for approval. This sounds to me, this is a transformation plan, which could be part of a strategic plan, or it could be a more detailed transformation plan in and of itself. So I'm thinking that what we really need to talk to, and it might be talk about, and that could be item number 3, is what is the structure of our plans? In other words, I've been thinking a strategic plan is our overarching plan. And we know that we have some plans under that, like the facilities master plan, that's a subset. Transformation plan like this is, could be a subset. And there may be some other subsets. But I think we're missing the overarching piece, basically because we're still operating off the health equity plan, which to me was our strategic plan, but it definitely needs updating. So, so my thought is, and I can wait till we get to number 3 if you want, but my thought is that we need to provide direction, which includes the kind of things you're talking about, to staff to develop a strategic plan. And we need to provide direction on what is the components of that plan. And then talk through with Dr. Lee and his team about what's a reasonable time frame to get something like that back to us. And then talk through, make sure we're all clear on what the components of that are, you know. So I guess I'm just taking your thoughts and kind of adding what I've been thinking about.
And I would think, Ann, is that almost in a way, this would have to almost be disarticulated into separate, these different
Different kinds of subs.
different concepts.
Yeah, I
that
agree.
I think are
I agree.
the larger vision for
Right.
our mission, really.
Mm-hmm.
I think, and for us to articulate that as a group to each other about a system that we were all left very impressed with,
Mm-hmm.
to say, let's have these pies in the sky, but discuss it as a board for that strategy.
Well, I think that's a great idea, and this is really what we need to focus on, because we can't get to the future if we don't know the road, so we need to make that road. So maybe we could start and actually do this for our next strategic planning meeting. Let's ask people to be really thinking about their San Antonio trip, what they loved, where they see their vision going in different aspects, and bring it, and let's start making the plan, because we need a plan.
Okay.
Yeah. So, and if we needed to, we could maybe not wait 2 or 3 months for the next strategic planning meeting, but
Yeah,
maybe
you might want to do that in
maybe
December.
do it in December.
Yeah, very much so.
Okay, so
Okay.
that's what we'll request to do. Yes, and Manager Besaita.
Thank you, Chair. I have a couple questions. The first one, we're all on item 2, just want to make sure,
Yes,
correct?
yes.
Okay. So in terms of the access, now, right now, where are we with wait time? Because what you made it, whatever, was presented was very glorious and glamorous, but also just want to understand the numbers and the data behind it. So just where are we today right now? And also the launch of these new additional specialty clinics, how many patients have we already seen, and what's our capacity? How can we amplify the resources that we have for our population that is growing? So I would like to have more concrete data if that's possible, and I think that is something we've requested in the past, but so is this information available at this moment in time?
So these are great questions, Dr. Musaitif. The average wait time across the system is approximately 4 weeks currently. That is consistent with the national average, so we're seeking to improve that by half. There's a lot of variation around that number, so depending on the location, especially service line, it could be less or it could be a lot more. But the average, as I understand, is about 4 weeks. In terms of the number, especially if it is delivered, on page 23 of the packet, you can see that in FY25, we delivered 20,461 specialty encounters. This is rolling up across all of our different specialty service lines. There were 19 service lines, specialty care service lines in total, that this represents. The goal had been 13,500. We went right past that. And this year, as I understand it, our target is going to be in the mid-20s range, but we can have John Morgan circle back with the exact target for specialty care. So those are sort of our overall ranges that we can always break down by service line, but this is the roll-up across the specialty direct practice.
So I would appreciate if we can break it down by specialty and how long they've been in inception. I think that is really helpful for us to know. And second part, when you're talking about 4 weeks timeline across the system, can you be very explicit what you mean? Is it primary care, specialty care, because I know those weights vary. So can you, what do you mean by across the system?
My understanding is this is the average across the entire ambulatory system, but we can get back with a little more detail line by line. So we'll take that maybe as an action item to show the board. So what I heard, just to be clear, is when did the specialty start? Because they all start at different times. What is the current volume in those specialties, and what are the wait times? Am I hearing correctly?
Correct. That I think that would be helpful information for us and for the community as well. Thank you.
Okay. I think we've
That's helpful.
hopefully grabbed that action item. We'll bring it back. Thank you.
Yes, Manager Kitchen.
Yep.
I'm sorry, you may have mentioned it, but, so our current, did I hear this right, that our current average wait times is 4 weeks, is that right?
That is my understanding.
Okay, we had, what was it before? Did we improve it at all in 2025?
In many cases, the wait times are over 12 months
Yeah,
in
okay.
duration. We can bring some of that back in terms of the historic data and the current data when we bring this update back.
Okay, yeah, I would like to know specifically where we've improved wait times.
Okay.
Okay,
Yeah. Somebody just get confirmation. Who has grabbed this action item for? Lucas, you got the ball? Okay. So we've got that. We'll prepare a little more deeper dive on these service lines. Thank you.
Manager Valdez.
Mine's just going to be a very quick follow-up, because I personally have also asked for this. We needed to have a baseline so that we would be able to measure the improvement. Okay, so this was what we were at the beginning of 25. We're going by fiscal year by fiscal year. Okay, this is where we were at the beginning of the fiscal year. This is where we are now. We'd be able to see quarter by quarter. In addition, not the total number of encounters, that's good and fine, but it doesn't mean anything to me if I don't know the demographics of those people, the patients that we are treating, and also broken down by MAP basic, if they're Medicaid or something else, because our patients are all the patients in Travis County, yes, but what's important for me also to know is how are our MAP and MAP patients improving? What are they experiencing? If they are still stuck in the 4+ week wait time, then I don't know maybe it was 12 months before. We've been talking about 12 months for at least a couple of years, because at one point in time, we were not getting that wait time information, and we used to get it. So that needs to be a regular ingredient or a regular part of the accomplishments to that detail, and it shouldn't be that difficult to get, because we know who we're seeing. That's on the computer, just print it out. So that's my follow-up to them.
I have one question.
Yes.
Oh, I'm sorry, go ahead, Shannon.
No, you,
No,
go ahead.
you are.
Mine is a different.
My topic is more work for y'all. I think that to look at results, since we are a medical provider, for Alan and perhaps staff to come up with some medical metrics, number of A1Cs that have been met, hypertension measures, that Alan would be able to bring that as a metric, that these are the things that we've decided upon, quality metrics, in terms of health, colorectal screening, whatever the case may be, that y'all can decide, and then bring those results back to us as, I think, as a metric would be very valuable if we're actually doing our job.
Yeah.
Did you also include readmit to hospitals?
Yeah.
Did you also include readmit to hospitals or clinics? Because now as we're looking at the ACA, less people probably buying into it. They're going to be just going to the doctors or the ER or the clinic on an emergency basis because of the cost. And so it would behoove us to know that exact impact on the quality of our patients' care as a result of not having access to a healthcare plan or coverage. So, and also to see whether or not doctor visits are meaningful.
But is that a metric that, A, we can impact since we don't control the ACA?
No, but they are our patients.
I
We
get
would
it,
know.
I get it, but what is the action you would want from us? If they don't have insurance, what is the action?
Well, on the
they're gonna
insurance, it would
readmit
be,
because they're
are
not
they
following.
MAP? Are they MAP basic?
Well, then they do
Are
have-
they ACA, you know, which would be Medicare or Medicaid, or, you know, insure, or self-pay, you know?
I think it's a good idea, Cynthia. I'm just saying, I don't know what's actionable for us to do about that. I mean, we do control MAP and MAP Basic, but the people whose insurance, yes, it's gonna be a cluster, but I don't know that that we have actionable data that we can do anything with it. really.
I guess, Dr. Martin, and for those of you that are listening, the reason I'm saying that it is important because if we're going to use terms like all the Travis County residents are our patients, we're serving Travis County, we're serving Travis County. Well, if we're serving Travis County, then let's take responsibility for that and hold ourselves accountable. And we're not gonna be able to do that if we don't know what the information is. That's the data, and that's the only thing I'm doing is asking that it be, I guess, we collect that data so that we will be able to see whether or not we're impacting any change in closing those disparity gaps.
But Cynthia, my point is, if they're MAP or MAP Basic, they're in our system, and they get discharged from the hospital with a diabetic foot ulcer, they're gonna have follow-up at our clinics. It's the patients who are gonna fall out, or the patients who are in the ACA currently.
Or the 150,000 that we still are citing as uninsured, not coming into our clinics, which is one of the concerns
But-
I have continued to have. How are we measuring those 150 to 200,000 people in Travis County that are not receiving services? I have not seen any measurement of whether or not we're impacting those people or bringing them into the system. Or are they transitioning out because they're moving to another county and those numbers are remaining the same because there's a different set of people? That's also something I think we should think about.
Seems like both of those things that y'all are asking for are possible. What you're asking for, to the extent data is available, and you're zoning in on the more specific data we should have. So Chair, it sounds to me like those are two asks that would be useful to have.
What I feel that I'm hearing is that we need to make some decisions on what needs to be measured. And
Okay,
we
yeah,
may
that's
choose
right.
to do that,
That's right.
you know, as a, like, okay, we're just standardly, we're gonna measure our hemoglobin A1C numbers. And we're gonna do that every year, you know, but what are the things we're gonna do as special projects? What is something we might wanna just do every 5 years? So I think we need a plan, and I think we need to meet in a month, and we'll also need to really work on that.
Yeah, some medical metrics. I mean,
Yes,
rate of
medical metrics.
myocardial
Right.
infarction, rate of
Right.
amputation, and the medical director should design that
Right.
and then say, these are
This
the
is what-
metrics,
what we
and we've
think, yeah.
succeeded at that and
Right,
whatnot, so.
right. Yes, sir.
I agree with my colleagues in terms of the need to be able to have this data. I think we need to inculcate into that the demographic profile and the geographic profile of the data, because it's been my experience to have seen trends occur over time. And if it's not mapped out, or if it's not clearly understood what population, we're unable to dig down deep and see what trends are being impacted in our community. So I would just encourage that be part of the plan as well.
Are the deserts getting bigger?
Right,
Yeah.
right.
And Manager Ms. Active?
Yes, I want to follow up on the metrics. So these metrics need to be evidence-based indicators based on quality, national quality metrics that are collected. So if we can adapt some of those quality metrics from the Agency for Healthcare Research and Quality, National Committee for Quality Assurance. So some of these really national agencies are collecting these evidence-based metrics rather than we're just collecting like off bat. So it's based on evidence-based and what is typically collected across health system. And I think, and then we can decide on which metrics we want pertain to central health, but we should start based on evidence-based metrics. And I think it just follows back to what Dr. Martin has suggested.
And I would like to, thank you, Madam Trustee, but I'd like to argue that we should not decide that.
Right.
The medical board should decide that,
Right.
about what those metrics should be.
Yes,
They're well-known in the national community,
yes.
heart failure, deaths, amputations, yada, 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 and we can watch that
Right.
as we deliver excellent care, those things not occur to our patients. So, but I think that decision that's in the weeds, that's really for the physicians and the group to decide.
Right, I agree, I agree. But we can take that up at our next medical meeting.
There you go.
Yeah, you should.
Okay,
I have one last thing.
yes.
It's a question on page 27. It's under O2. It says to establish an ambulatory access and quality plan and present it to the Board of Managers for approval by the end of fiscal year 2025. It says 100% completion, but it hasn't been presented to the Board of Managers for approval. So I would ask you to just go back and really look at these completion to date. I just looked real quickly and noticed that one, but there may be some places where it says 100% where it's not quite completed. So can you do that? Can you go back? Okay, because this one has not been completed and it shouldn't say 100%. Okay.
Yes.
Just a very quick follow-up to that question, and I guess to Dr. Lee. I see the I guess the OKRs, they were put here per quarter, and who would be responsible? Who developed them? Was that done by you?
We voted on them.
No, I
Okay.
remember that. I remember
Okay, go
that.
ahead.
But I was just curious, is that anything that y'all inherited maybe from a previous fiscal year, or a previous, maybe something from CUC, or as to how that information was presented, and this is something we need to incorporate into our standards? And I was just, or is that something that you got from as Maram has talked about, and that is national standards that we would be looking at to incorporate into our practices and metrics? I was just curious.
That's a great question, Manager Valdez. So in FY25, you may recall, we had actually two sets of OKRs. One that were derived from our budget resolution, which was a direct line from our healthcare equity plans we discussed. So those came through the Central Health Board and that whole process, strategic planning and budgeting. Then there was the system integration OKRs, if you will. Those are developed collaboratively for the first time with the Community Care, Sendero, and Central Health executives, like 19 of us, maybe meeting in a room, closing the doors for the day, and agreeing first on the 4 high-level goals: the seamless patient journeys, the comprehensive equitable systems, demonstrating the value of community support, and empowering and developing our team. Those things that we've seen carry throughout. And then, so those are sort of the objectives. The key results for FY25 were then developed underneath those goals, and iterated together with this board. And so that's how we arrived at the FY25 goals. And then for FY26, we've kind of cleaned them up even further. And now they're all under those 4 pillars. And we have 12 of them, as you know, for 26. Thank you for the question.
Okay. Any other questions? No? Okay. So now what we're going to do is we're going to move into, I believe, closed session. And so we're going to, we are convening in closed session to
Chair, I have a question.
Yes.
We're going to be talking about item number 3, right? Strategic plan. My thought is that we should discuss the strategic plan in open session, because the development of a strategic plan is a public document. So maybe we could start an open session, and then if we hit things that are competitive, which is what I'd have to ask our attorneys, but that's what would put us in the closed. But can we do it that way? Can we start in open?
Chair, it's we can start an open however you like to do it. I think the presenter would be able to also tell us what he or she is going to be discussing,
Okay.
whether we should go back in or out, but 085 is pretty broad in terms of systems planning and medical planning and also medical pricing and stuff. So,
Well, the document that I'm looking at that I understand is our backup document is not, well, we can talk about it, but from my perspective, it doesn't look like it requires closed session. And because the strategic plan that we have to adopt is public, I think it would be better if we talked about this in public. So anyway, that's just my perspective.
if it's a final product, I'm not sure. Dr. Lee could probably speak to if it's what he's going to present is final and stuff.
It's not final. This board has to adopt, so it's not final, and that's not the criteria.
Well,
right?
What's in backup is public. What's in backup right now is public, but I don't know if there's going to be other information and that the presenter or presenters are going to present. That's going to be proprietary.
Well, there's nothing in backup for item number 3.
Yeah, we're gonna be, so,
I thought we were talking about this document. Are we not?
we are, yeah.
Okay.
There's some closed session material that we were gonna hand out once you go into closed session. I was gonna
Okay.
provide an overview connecting several closed session elements to the open session element. So the overview, as Steve has mentioned, will cover elements that should be presented in closed session.
Okay, so maybe we start in open session with the items we can talk about in open session, which is this, and then we can move to closed session.
Or we could do the reverse. We could start in closed session and then do a summary in open session.
We could do that. We're just gonna have to repeat ourselves, because I have some comments about the document that I think is an open session comments, so. But it's up to the chair, however you want to do it.
Chair, I don't have that document. I don't think that you're referring.
It was a document that was sent out to the whole board.
When was it sent out?
I think Pat sent it last week to the whole
We
board.
have an extra one. No, I don't have it.
We're gonna be passing all these out at that.
Oh, okay.
Yeah, if we could get them all passed out at the same
Perla,
time.
can we go ahead and pass out the materials? Yeah, if we could. They're coming around. Manager Jens, thank you.
Thank you.
Is this new material?
That's the one I'm talking about for open.
Would you repeat that, Manager Musaitov?
Chair, is this
Oh,
new
new
material?
material. Some
they're
of the
handing out?
material was sent out to the board members last week.
But are the material that they are circulating, have they sent it to all members, even if it's enclosed?
I don't know what they're circulating, so.
Oh, okay.
The board may recall that we presented a strategic framework in closed session and last retreat. So I'll be briefly connecting that closed session framework to this open session document and the sort of framing of the discussion. So that's the main reason why we would want to go into closed.
Is that also including the system transformation policy draft that we did receive last week?
Yes, it is.
That's the part I think should be open.
Yeah. Did you hear me, Maram?
She didn't hear you.
Maram, I was referring to, even though there's nothing in our backup documents here, I'm assuming that one of the documents that they're talking about is the system transformation policy draft that was sent to us last week. And I know that not everybody may have printed it out or looked at it.
Yes, I did look at it, so it was emailed.
But Shannon hasn't got it, so if we can please go ahead and get our documents passed out to us so that we're not waiting for somebody to pass us something.
I think for me, it would feel smoother if we opened in closed session and then did a summary in open session after we've had our discussion. To me, that just feels like,
It's up to you, Chair.
yeah,
So
I
that's
think
fine.
that feels more, like it would be more enclosure, so that would be good. So let's move into closed session and we'll begin there. Yeah, okay. So So I announce that the committee is convening in closed session to discuss agenda item number 3 under Texas Government Code 551.071, consultation with attorney, and Texas Government Code 551.085, governing board of certain providers of healthcare services. Item number 3, review and discuss a draft system transformation policy and strategy framework. Dr. Lee will be presenting. Oh, the date today is
November 12th.
November 12th, 2025, and it is 1:53 p.m. All right, we are moving into open session, and we are going to say that. Oh, yes, it's November the 12th, 2025, and it is 2:43 p.m. And in open session, we'd like to review our plan on the review and discussion of the transformation policy and strategy framework. And Dr. Lee will be summing that up for us.
Okay. Thank you, Chair Brinson. So maybe what I can do is begin by briefly describing what we talked about, and then Chair Kitchen, would you like to build on kind of what happens next?
If it's okay with you, Chair, I can kind of summarize where we ended up, and you can tell me if I got it right.
Okay, sounds great. So, in closed session, amongst other things, Chair Brinson, we talked about a draft system transformation policy and board note. That policy draft directs the CEO and staff of Central Health to establish within 5 years a comprehensive coordinated continuum of care that ensures timely, equitable, and high-quality whole-person care for everyone who needs us in Travis County. It directs CEO to engage patients, communities, and partners in designing that system, to prioritize direct delivery of care by Central Health System entities, while cultivating high-performing partnerships grounded in shared accountability and aligned incentives. Directs the CEO to use the district's financial authority and statutory powers within board governance direction, including maintaining prudent reserves, using debt wisely, and leveraging every available funding source to achieve measurable progress in board-directed targets for access, quality, and equity. And the accompanying board note explains why the transformation is needed, highlighting the human and financial cost of today's disparities and the opportunity to create long-term taxpayer value through this upstream investment in a comprehensive system. It postulates 2 long-term goals by 2035, a 50% reduction in health disparities and a 5-to-1 taxpayer return on investment. And importantly, the opening section of that board note captures the spirit of the policy. Quote, through this policy and under the continued stewardship of the Board of Managers, Central Health commits to transforming a fragmented safety net into one connected, trusted, and accountable system designed to serve the people of Travis County today while safeguarding the community's health and resources for generations to come. And that sentence brings the work full circle, how the board fulfills Central Health's dual mission to care for those who need us most and to deliver exceptional long-term value to the taxpayers who make that possible. So that was the overview of the note and policy we discussed. And then, Chair Kitchen, would you mind summarizing the next steps?
So, Sharon, you can tell me if I got this right. So, we acknowledge that a strategic plan is a public document. We acknowledge that developing a strategic plan and presenting it to the full board is a function of this committee. We talked about the fact that what Dr. Lee has presented is something that, we can work with, but what it is missing is the paragraph or 2 paragraphs or whatever, but it's missing the language that speaks to the board's governance role, and that's something to be developed, and that the purpose behind developing the board governance role in editing this particular language is to provide clarity in the direction we want to go to develop a strategic plan, and clarity on what the board is setting direction on, and so that Dr. Lee has clarity as he moves forward with implementation. So that's kind of high level, and I think if I heard you right, that the other thing we were talking about was timeline, that the next strategic planning committee would be the place to have further conversation about this along the lines about what we discussed for editing and fleshing out. We also talked about the fact that as an entity, for Central Health, we need to develop that overall strategic plan. What we've been operating with is an older plan, the health equity plan, that just needs updating and needs to accommodate the kind of transformation that we've been talking about. So, so I think that's so to summarize that, we're working towards direction that the board can adopt, that will then direct Dr. Lee and provide some clarity to Dr. Lee and his team in terms of putting together the strategic plan for us, which serves as the overarching plan for the other types of sub-plans like the facilities master plan and other things that we are working towards. Did I get that right? Okay.
I just want to make sure that we don't exclude the financial component and need
Yes.
to be a part of this.
Yes.
And so we will begin honing in on these specifics at our next Central Health Strategic Planning Committee meeting. And so we are going to confirm the next Strategic Planning Committee meeting date, time, and location, and it will be on Wednesday, December the 10th, 2025, at 1 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. And at this time, I am ready to accept a motion for adjournment.
So moved.
That's great. And a second? Yes, thank you. Thank you, Manager Jones. All in agreement? Oh, you don't vote.
Oh, wait,
Okay.
I don't.
Yes.
Let me accept this here.
Thank you so much.
Thank y'all.